Great. Good morning, everyone. It is Thursday, February 2nd, Groundhog Day. 6 more weeks of winter is what I understand from my son.
Surprise, surprise.
Surprise, surprise.
Already happened.
Right. And it's just started today, I think. So welcome, everyone. We are doing a day of budget overviews today. And so different from the budget adjustment, where it came out as pretty fast and furious, we'll do updates from all the agencies today, just as an overview, and then we will have much, much more testimony where we need to over the coming weeks versus, the 5 or so days we had for budget adjustment. So this will be, I think, a high level. We'll have them walk through their recommendation and see where questions go, but know that this may not be the last time. And we'll do some introductions. So let's start with Joe. You want to introduce yourself?
Hello, my name is Joe Andriano. I live in Orwell. I represent Orwell, Shoreham, Whiting, Sudbury, and Hubbard.
Alan DeMar representing Enosburg and Montgomery.
Alyssa Black representing Essex Town.
Houghton, City of Essex Junction.
Daisy Rebecca representing Maynooth.
Leslie Goldman from Wyndham Free, Rockingham, Westminster, and Brookline, Ellis Falls area.
Art Peterson, Rutland District 2. I represent Clarendon, Wallingford, West Rutland, and a piece of Rutland Town.
And just for your benefit, I know normally you don't come into our committee, but we are working much closer with Human Services this year. So I think we will try and not make it duplicative to you, but it will be, I think, helpful for us to both understand the budget requests to put some recommendations forward. So I'm going to let you two introduce yourself and turn it over to you.
Yeah, Commissioner Mark Levine, Department of Health.
Anna Swenson, Finance Director, Department of Health. I'll share my screen.
We're delighted to testify on budget, and we're going to do a little bit of a tag team.
Okay.
The things that are most appropriate for the financial specialist is in her ballpark, and I'll be elaborating on a number of other items as we move along.
Great.
Although I will start. It's a tag team. So since you don't deal with our department all the time, let it be known that we have the coolest mission statement in state government. It gets us all up to go to work every day with enthusiasm and high aspirations to protect and promote the best health for all Vermonters. You'll also see our vision and some of our values on the slide, but that's the major punchline. And then the pie diagram is really important to look at as a part of our whole budget. We rely tremendously, as you'll see in that bottom half of the pie graph, on federal funds and to a significant but lesser degree on global commitment money. And the sliver in blue, that is general fund, is modest, though always important. We were talking about an almost $217 million budget, and you can see what those percents turn into in terms of dollar numbers on the right side of the slide, with the federal vastly dwarfing many of the other numbers. Bottom line is we have 3 appropriations: administration support, public health, and substance use. And our overall increase in budget is 5%, which provides full funding for the department's current service budget. So we're going to go through some of the easier sort of line item things that just happen to come first anyways. And I think what we'll do is go through each appropriation, and then we can stop and have questions at
Perfect.
the time.
Great.
Unless there's something that's totally undecipherable on a slide to someone that they just have to focus on right away.
Great. Sounds great.
Okay, so starting in the administration and support appropriation. So this slide shows the full ups and downs. It's also called the budget crosswalk, the budget development workbook. So this essentially shows the starting point from FY23 and then all of the changes and then the final FY24 as proposed. So we'll go through the line item detail on the next few slides. You'll see to the left, there are numbers, and those numbers align to the numbers on the next few slides with the line item detail.
Daisy? Did you have a question, Daisy?
No, she's got it. Is that helping a little bit? The other thing is you can, we have a link here, and you can click on that link and go to the Agency of Human Services ups and downs, and this appears on page 9.
Thank you.
So a number of routine line items here. The first item is salary and fringe. So that's an overall increase of $41,000. That reflects the change in salary and fringe for existing positions in 24 over 23. This particular amount excludes the impact of changes in the retirement rate. You'll see that as a separate line item further down. Line item 2 is a technical adjustment, fund splits to earnings. So essentially what we've done here is we've updated the fund split for positions that are funded by departmental administration to be better in line with what we expect to see in 24 and what we've seen historically. So that's just overall a change in fund split for those positions. Sure.
Number one, salary and fringe, that isn't the figure for the whole state, is it?
No, so that's just for the administration and support appropriation. We do have 3 appropriations and the largest one is public health. So you'll see a larger salary fringe increase.
And it's just the up,
Yeah.
right? It's not the starting point. It is just the up from the starting point, which we are gonna, I know that's a concern of yours. We are gonna have someone come in and tackle that with us.
Okay, I didn't know in my pea-sized brain, wondered if that was the amount of increase per person that works for you.
No, so that's the overall
Okay,
increase.
gotcha.
Change.
That's all I care about. Thank
Okay.
you.
We're so used to, as I say, this is millions? This is just that?
No.
Right.
Oh.
Well, then the next one was $64, right?
Yeah, so it's like, huh?
Okay, go ahead.
Sorry.
So then line item 3, that's an adjustment to vacancy savings. So we're updating vacancy savings to be in line with what we expect in 24. Continuing with personal services and the admin and support appropriation on the next slide. Retirement, as I alluded to earlier, we have an increase there. That's line 4. Line 5, we do have 2 new positions in the admin and support appropriation. So this is the salary fringe associated with those 2 positions. They are both fully federally funded and limited service positions.
So can I ask real quick, so is that state dollars or is that federal funds? Okay.
And just explain for a second, a limited service position as opposed to what?
So a limited service position, they're often created that are federally funded positions. They have a set end date.
Okay. As
So they
opposed,
can be extended,
They can be
but
extended.
they're tied to a specific funding source.
thank you.
Sure.
The person enters the position knowing.
Okay.
Right. That it's a 3-year grant or a 2-year grant or, right.
Within the grant then, okay, got it.
So line item 6, that's the estimated FY24 impact of position class action reclassification requests. And we did have 1 position that was included in a reclassification request in the admin appropriation. So that's the estimated impact there. Line 7 is an internal service fund charge, workers' compensation. So that's actually a slight down over 23, and that amount was provided to us by finance. Moving on to operating expenses, we have some more internal service fund charges in the admin and support appropriation. So the overall increase here is about $250,000. And that's over 5 line items, and that detail is listed there. Overall increase again of $250,000, and these amounts were all provided by finance.
Can you just, again, so we have several new people. Can you just describe internal service charges?
Sure. So these are charges for services provided by other state departments. So, the first line item, ADS, that's the Agency of Digital Services. So that's the amount billed, so this is the increase in the amount billed from ADS to the Health Department for services provided. DHR Vision is the financial system.
Okay.
And HR stands for?
Human
Department of
Resources.
Human Resources.
Thank you.
Sure. So line item 2 on this slide, net operating expense account code changes. So this line just reflects changes in the funding mix for operating expense account codes based on historical actuals and expected funding. You'll see that that line item nets to 0. So it is just a change in the funding mix, not a change in the overall amount budgeted for the expenses.
Okay.
And then finally, in the admin and support appropriation, we have one change in the grants major object. It's a down of about $2.3 million in global commitment. Essentially, during the 2021 legislative session, the General Assembly appropriated one-time funding for a temporary expansion of a program for scholarships for medical and nursing students. And that was a one-time expansion that those funds won't be available after 23. So we need to remove that for the 24 build.
So can I ask a couple questions on that?
Sure.
So and I apologize, I'm really bad at remembering the ACT numbers. Was this the ARPA funding or was this, you said it was global commitment funding?
Yeah, this was a global commitment. It was actually in the 22 budget bill.
22 budget. And so in your budget, not having read ahead, is there any funding for scholarships for nursing and medical students?
Yes.
Okay, great. Thank you.
This only is the one-time funding
One-time.
change. The other baseline continues.
Great, thank you.
I was wondering, a couple days ago, I heard on the news that the Biden administration announced they're ending the public health emergency. Does that affect any of the numbers we're seeing here? Is that because I know there's a lot of federal funds here, or is that already taken into account here?
Most of those I would categorize in the category of sort of human services kind of funds. Things that wouldn't normally appear in our budget, like the cost of vaccines, the cost of tests, Paxlovid treatments, things of that sort. So they're not even in our budget from the start.
Great.
But you've posed a question that's going to be huge because there are going to be abundant downstream impacts of that announcement, which in 2 days, nobody could go through it all to figure it out yet. But that's going to be a big topic of conversation at the agency level.
Great, thank you.
And just so you know, I just talked to DEVA this morning and I've asked them to start compiling policy issues that will be coming up from it. It won't be anything we hear today, obviously, because the announcement just happened, but we will make sure we have that.
That's huge.
And you know, the biggest contribution of our department in the pandemic was sort of all hands on deck workforce. And we've already changed that to a huge degree in terms of who's dedicated to the ongoing COVID effort and who is not and doing the work that they should always be doing. So this announcement actually has no impact on that because we'd already created the stream of work. Everybody knows who's doing what. We have a modestly sized COVID unit now as part of our health surveillance or laboratory science and infectious disease epidemiology section.
Okay, so that concludes the administration and support appropriation. We'll move on to public health. So again, this is just a summary slide showing all of the changes that we'll discuss in more detail on the next slides. So again, personal services and the public health appropriation, you'll see many of the same line items that we saw in administration and support, the salary fringe increase, again, the technical adjustment, vacancy savings adjustment, retirement. And in this appropriation, we have 26 new positions. Again, these are all federally funded and all limited service.
I didn't hear the end of that. I'm sorry.
That's okay, go ahead.
All federally funded and limited service positions.
Limited service position, you said? Okay, so these are like the others, they will
A set.
have a sunset.
date, yeah.
Okay.
They're tied probably to a grant, so.
Okay, and are those grants continuing this fiscal year?
Yeah, so these positions are actually funded by two different federal grants, and they both, one runs through, I think, the end of June 2024, and the other one is through June of 25.
Do we actually terminate folks when these grants end, or do we find other jobs for them?
We tend to do a transition process where we notify folks if the grant is ending, see if we can find other work for them. But it's a process in terms of when they get hired, they know that there's an end date, but we do try to, make it a transition process. It's not a,
Okay.
hard stop, I guess, if that makes any sense.
I'm just curious about number one, the $2 million. What does that represent?
So that's the change in salary and fringe for positions in the public health appropriation.
So did we put in an increase or so where does that come from?
This is, contracted salary increases. So, the steps.
Okay, yes.
Yeah.
For all employees across the board.
In
In that department, right, in that, right.
Exactly.
Which
So
is
that's
the
what you're saying.
largest.
It's all negotiated. That's what I'm learning. Yeah.
Negotiated,
Okay.
through
How
the,
many total employees roughly? I mean, I know you don't.
it's about 650 in the total
department.
Yeah,
This appropriation would be
it's about 5.
3/4 of it,
Yeah.
3/4 plus of it.
Yeah.
Yes, 60. We are at the largest employee numbers that we've ever been at due to the fact that Congress and CDC through Congress has funded a whole bunch of positions. Laboratory positions, epidemiology positions, health equity positions, some emergency preparedness, things that you'd expect coming out of the pandemic. So if Congress's vision is on the distant horizon, some of these positions you're worried about would actually get renewed. I wouldn't count on that because I don't trust much of what's going on in Congress at this point in time. Even though everyone says we've learned our lesson, public health was underfunded for decades. The workforce was constricted, actually down, whatever the word is, degraded for several decades. So we'll see what happens.
Okay, so moving on. We're into operating expenses for public health appropriation. So the first line item here is an increase to for the opioid antagonist utilization. So the health department provides naloxone, which is a medication that can reverse an opioid or an overdose caused by an opioid. And we collaborate with community partners to distribute that. There is an increased demand for this drug. So we're requesting additional funds to meet that demand.
What is the special fund?
So it's a mix of two special funds. So currently the program is funded by the Evidence-Based Education and Advertising Fund. That does have a set amount of revenue. So we're requesting $400,000 in additional special fund appropriation from that fund. And then we're requesting $1.98 million from the opioid abatement special fund.
And I apologize for all the questions. Again, this is new to us. So is this the fund that is, and I'm not going to get the language right either. Is this the fund that's tied to the committee that was created last year by our legislation that's determining what to do with, okay,
The second part.
the second part, okay.
First part is a actual fee assessed to manufacturers that they've been contributing to for I don't know how many years now. The increase in expense for naloxone, it's gone up tremendously in price. The fact that we're deploying more of it than ever before and want to be able to deploy even more than that. And the fact that people no longer can have one dose. It requires 2 doses because we're in the era of fentanyl. So lots of reasons why this has become extraordinarily expensive. So this opioid settlement advisory committee
Thank you.
is meeting again a week after next, where we'll have a number of suggestions about how the first allotment of settlement monies could be spent.
And do we know how much that first allotment is?
3 million.
3 million, okay.
And there'll be a lot more than that, but the only one we are confident about right now is 3 million. It's the Sackler family. And that one will renew itself over 18 years each year. So it'll be 54 million. As will several of the others that are in process, but we don't have the firmest commitment from them yet. So they've gone through litigation. Attorney generals across the country have all worked very hard. And so there will be a fair number of more settlements coming our way.
Okay. And just for the folks on the committee, so remember Leslie and Mari are the two that are working with Human Services on a subcommittee to bring our two committees together. Dane is also on that committee from Human Services, and I believe he sits on the advisory council. So this will be something that they will discuss as a group, along with our budget liaisons, just to make sure everyone's tied in and determine whether or not this is something that I would say we're going to look really to the advisory council on this one to determine and make suggestions on where the money goes. So thank you.
Great. So moving on to additional items under operating expenses in the public health appropriation, another internal service fund charge fee for space. So it's just the increased cost of that over 23, increase of about $163,000. And then again, as we saw in the admin appropriation, we have another net operating expense account code change line nets to zero, just changing the fund split for operating expense account codes. And then finally, in the public health appropriation, we have 2 line items. Oh, sorry.
So where are you located? Like when you're talking about the space
In
or,
the form.
no, literally, where's your office?
Sure. So we're located in Burlington.
Okay.
The fee for space charge is related to some of our district offices
Okay.
and also the lab in Colchester.
Okay, so you're like renting space or whatever it is,
Right.
Yes.
Pay to BGS for,
wherever it is.
yes, for the space.
I don't really understand your,
Yeah, we have a central office where closer to 400 of the employees are.
Okay.
And then we have 12 district offices,
okay,
as well as the public health laboratory, which is in Colchester.
okay, and the public health offices respond to the HSAs? The health service areas? Not necessarily,
They do, but they're really set up by district in Vermont.
okay,
So they're very geographically appropriate, but
Yeah.
at the same time, not quite.
not quite that same geography. Thank you. Okay,
Yeah, I just to clarify about the space, on this topic. You have, in Burlington, you have a lab on the corner of of Colchester Ave and East Ave, right? You used to.
That was decades ago.
It's not no longer held.
Now a much more modernized lab in Colchester at the industrial park,
Oh, I know where.
where UVM has.
That's where I went and got my COVID test when I
Yeah.
almost infected everyone here. So they sent me the
Well, we
parking lot.
yeah.
The parking lot so what's so here's where I'm going with this is there's 2 buildings in Burlington that the Department of Health was connected with. One is the one on the corner of Colchester and East Ave. It sounds like you're not using that anymore for the Department of Health. And then I remember the Department of Health had offices on yeah, it's Pearl and Cherry where the bus stop is and the Zampiri.
That's right.
Are you still there?
Yes.
So what's the plan if that gets sold? Because I heard that that there's talk about selling that.
Right. So that, in the governor's capital budget is proposal to sell that. If the legislature concurs by the end of the legislative session, that would be put up for sale. And then we envision 12 to 24 month process before anybody would actually have to go somewhere else to relocate, starting 12 to 24 months starting now. The hope on the part of the Agency of Human Services is this would use space that's being underutilized at Waterbury, because both our building and the whole Waterbury complex have now impacted by hybrid work. So people are not necessarily 5 days a week in their office, so to speak. So depending on what their hybrid arrangement is, there are a certain number of days a week actually located with colleagues in a work setting. So the goal is to become more efficient at a time when the building in Burlington actually needs a significant amount of investment in it because the parking garage is literally falling apart, which is under the building.
Yeah.
And both buildings are not fully utilized.
Okay. We don't need to take more time on it, but since Leslie, Representative Goldman brought up space, it brought it to mind. Thank you.
Oh, and it's good for us to understand.
Yeah.
yeah, I appreciate that, yeah.
Okay, great. So to round out the public health appropriation, we have 2 line items in the grants major object. The health department has 2 memorandums of understanding, also called MOUs, one with DEVA and one with DMH. And these line items simply provide the spending authority for us to expend those funds that we receive via the MOUs. And finally.
I have a question on those.
Sure.
Why does a memorandum of understanding need more money? I mean, what is, I'm just trying to
What are the two
understand.
programs that are being, what are the two programs that
Right.
money is being paid, is being used?
And the
for?
structure of it, I guess the relationship.
Right, so like the big one, which is the self-management, that was work previously done by the Blueprint for Health, which
Okay.
is part of DIVA. It's really chronic disease self-management programs for patients. So
Okay.
people with diabetes, high blood pressure, asthma, things of that sort. The work that is required to both create and enact and develop those programs is all Department of Health now. So that work was essentially handed over to us. We agreed to it. And so we're doing the same work. So we're getting the cost allocation that is required to do that work.
We have a little argument going.
It's not with us, that's fine.
It's been a discussion and I think she's about to win. I thought the Blueprint fell under the healthcare reform in the secretary's office. She believes it falls in DIVA. Where does Blueprint
He's
sit?
like, oh.
I know. It's okay, we'll still talk to each other at the end. Do you know where Blueprint sits?
Where does it sit? I don't know.
Oh, good, see?
No,
Then we're
so the secretary's in here following us.
gonna ask her, thank you. All
I
right,
know that their report was submitted by Ina Backus,
Right.
Healthcare Reform.
exactly,
It was created by Dr. Saroyan, who is the Blueprint.
Blueprint. So I feel better that it's not just us.
And I got very excited when you said that, and I'm like,
All of the Blueprint expenses, when you talk about per member per month cost, and all
Right.
that is all part of the Medicaid system,
Exactly,
which is DIVA.
which is DIVA,
So
right. All right, well, we're gonna get that question answered next.
it's probably a several-fold answer, depending if you're looking at it administratively versus financially,
Right.
budget-wise.
Right. Who reports to who? Sorry to deviate from our discussion.
It's all good. It's going to become important because there's a major proposal
Yes, exactly.
that involves Blueprint for Health,
Community health.
the community health teams, the hubs that you're going to hear about here, and the Dulce program that you'll hear about here as well. It's just one agency proposal that involves all of us.
Great,
So,
great. Well, I look forward to hearing it. Let's keep moving along.
yeah, and then now we're in the third appropriation.
So third and final appropriation substance use programs. So once again, here's the overall view, and we'll walk through the line item detail. So once again, as we saw in admin and support and public health, same old line items, they're just summarized on this slide. In this appropriation, we do have two new limited service positions, again, fully funded by federal grants. The first line item under the grants major object in substance use programs, it is to convert recovery centers to GC investment. So this essentially just reflects a change in the funding for the grants to recovery centers. The grant award amounts will remain unchanged.
And GC is Global.
Global Connect, yep. And so next in the substance use programs appropriation, we have a realignment of the SFY 23 appropriation. It's essentially a change in the funding mix for some substance use disorder treatment. We are budgeting about 1.6 million for stabilization of the existing residential treatment providers. And we're able to leverage some Medicaid investment in order to do that. And then the remaining 954 in general fund is going to be used it's budgeted for treatment expansion.
So on the 1.6 million, that's the gross amount. Part of that would be Medicaid parts.
Yep, part of it is GF and part of it is Medicaid.
Okay.
So a big theme here that you're going to hear at several of these presentations is stabilization of the healthcare system. Part of the reasoning for what you see on this slide is a small component of the healthcare system, but an important one, which is the residential treatment facilities. of which we only have 3 in Vermont. So there's a continuum of what you can do in substance use treatment. Everyone here knows about the hub and spoke system. Hub and spoke system is by definition really an ambulatory system. People either show up at the hub or they are with their primary care or other spoke. And that's done outside of any inpatient setting. Residential treatment clearly is an inpatient setting, though it's not a hospital. It's just what it says, a residential facility. So that part of the system has been very stressed as a result of the pandemic, partly because of just outbreaks and the usual kinds of things COVID did across society, but it really limited the number of beds they could have open at any one point in time. They also have severe workforce issues, some of which were COVID related, many of which were just overall workforce related, like across all of the healthcare sectors. So they require a little more specialized stabilization this time around. And that's why we're trying to leverage as much of the general fund match for Medicaid as we can to increase the mix and increase the amount we can help by about 27%. So I think the bottom line is, though we're paying a great deal of attention to the residential facilities, there is still, as you'll see in that second part of the slide, opportunities for us to continue to work on other parts of the system, so-called sobering beds, recovery beds, things of that sort that really are part and parcel to success in anybody with an opioid use disorder. So there's a continuum on the slide, though it's weighted a little more heavily towards where the crisis is.
The stabilization. And is the 1.6 million mostly for increasing of Medicaid rates to try to open additional beds? Or to get to have the beds open that we already have?
Yes.
Right, yes.
Okay. Leslie, did you have a question?
I do, if that's okay. So in the best of all worlds, how many beds would that be?
Remember the total number.
I don't remember the total number either. We can get back to you, but
I just wondered about order of magnitude, not like, is it 4, is it 40, that kind of thing, not important. I'm also wondering if you have limits about how long someone could stay in the residential beds, like how does that work?
So that's Medicaid determined quite often.
Okay.
So commonly people are in the 21-day range,
Okay.
occasionally 28 days. Not like what you might hear from places like the Betty Ford Center or
Right.
whatever, where people with any kind of substance use disorder may go for months. If they can pay for it, they stay there for months. But the residential treatment system that most of our people in Vermont attend is basically going to be 21 days average.
And what happens after they're released? Is there a program?
So there's a whole aftercare plan.
Great.
They would presumably be going into the residential treatment with a already treatment plan, which would either be buprenorphine or methadone. And so you'd want to make sure that that was continued the minute they left. And so there would be a connection established with either a hub or a spoke, depending on the intensity of their treatment program.
Thanks.
One last question. Do you know the mix of payers? Is it mostly Medicaid? Very few commercial?
Yeah. I don't know about very few, but
But it's mostly Medicaid. Thank you.
and a lot of that has to do with the devastation of substance use disorder to people's lives.
Yes.
Okay, next up is a base general fund increase of $1.41 million for substance misuse prevention. And this reflects per VSA section 7909A, 30% of the cannabis excise tax revenue is going to be directed towards substance misuse prevention. So this amount, this 1.41 million, is the estimated 30% of that revenue in 23. During the 22 legislative session, the General Assembly established legislative intent to have a total of $3 million available for substance misuse prevention annually. So there is also a one-time appropriation of 1.59 million paired with the base in order to make the full 3 million available in 24.
Do you have any idea yet the nature of the prevention activities?
Yes.
Can you
So,
tell us a little bit?
so the word prevention is the critical word
Yeah.
because that is what this is for, as opposed to treatment, recovery, or anything else. And for fiscal year '23, 15 prevention grants were awarded. Now, these are done regionally to support what we call regional prevention coalitions, which are sort of evidence-based entities utilizing a strategic prevention framework that's pretty much constant from federal level down to the state level that allows mostly community and school level intervention with youth and susceptible adolescents and young adults. So these are not new in fiscal year '23. The newness is there's equity now because it's not just here or here, it's like trying to make it statewide. The equity involves regions. Within a region, there still may not be equity, depending on how large the region is and transportation, et cetera. So there's now for fiscal year '24, request for proposals within regions for further development of these coalitions to really bring the prevention activity down to the population level as close as possible. So, for instance, one of our more famous ones is in the southeast corner of the state, where we have now 2 decades worth of work showing that if you look at youth self-report through the Youth Risk Behavior Survey of use of nicotine or tobacco, alcohol or cannabis, you see this incredible drop in all 3 of those substances over several decades. And when it's interrupted, it's because there wasn't funding for the years that it was interrupted. So you see it level off or get worse. And then when funding returns, it goes down again. So that's a model. But again, that's not the only geographic location in southeastern Vermont. So the goal is to make sure that other parts of that region still have the benefit of being able to develop these. And that's what the RFPs are for fiscal year '24.
Good, great.
Okay, next up is a couple one-time appropriations, as previously mentioned on the other slide, the one-time appropriation to supplant or to be paired with the base for the full 3 million, and then a one-time appropriation and global commitment for hub expansion.
And I can go into more detail on the hub expansion. So I already gave you the sort of preface that there's a vision that the overall vision is better identification of what's termed co-occurring disorders in individuals with substance use disorder. And co-occurring can mean anything, but by and large, the most big ticket item in that category is mental health issues. And it's probably at the level of 70 to 80% of those with substance use disorder have an underlying mental health issue accompanying that. There may also be physical health issues that are important to identify as well. And there may also be non-opioid substance use disorders to identify, since the most common substance use disorder is actually poly substance use disorder, not just one at a time.
So that was mentioned quite a bit yesterday. So I just want to understand, that means more than one substance.
Exactly.
Okay.
So could be anything.
Okay.
Could be a person with opioid use disorder who also is using stimulants. It might be alcohol use disorder and then acquired an opioid use disorder on top of that. So if you go to a hub, by definition, federal definition, you have to have an opioid use disorder. But which is fine, but we want to make sure that co-occurring substance disorders and mental health disorders get identified in that setting and get managed in that setting. So a big part of this appropriation is to do just that. Much of it is workforce related, obviously. And there's also a component of trying to identify physical health disorders. whether that would be, provision of, but many of these individuals aren't going to other healthcare facilities. So it could be provision of routine immunizations, could be like we are doing now, identifying hepatitis C, since injection drugs often put people at risk for hepatitis C, and being able to actually treat that in the same setting. Because you can imagine when a person's going to a hub, especially if they're getting methadone, they have to go frequently, they have to go often daily, and they often have to travel there, spend the time there, and then travel back. Doesn't leave a lot of time in their life to do a lot of other things. And one of those other things could be going to other healthcare settings. So we'd like to try to kind of consolidate what their needs are and get them taken care of at the same setting. And we do hear that that's a need because there are many, many people who actually are holding down jobs and trying to, as part of their recovery, they're trying to return to, I can't call it a normal life, but the kind of life that they wanted to have. And the more that they're having to do in the course of a day, how are they going to actually get to work on time and get back from work, et cetera, and have gotten their dose of methadone? So that's sort of the vision for that. You'll hear in subsequent presentations and over time, the vision for the spoke part of the hub and spoke system with the blueprint model.
I was going to ask, that's the connection with the blueprint is the spoke.
And the Dulce part, which is the embedded family specialist in a pediatrics office who can identify at the time of newborn visits for both the mother and the child problems, whether they be medical problems, whether they be breastfeeding problems, whether they be home problems, somebody there who's incarcerated, who has been incarcerated, somebody there who's got a substance use disorder, whether they may involve the mother herself in terms of use of substances or mental health issues or what. So it's a very expansive kind of trying to address the kind of problems we actually in public health see all the time. And in our state, unfortunately, the rate of substance use disorders from tobacco to opioids in pregnant mothers and postpartum mothers is extraordinary.
Has it always been extraordinary?
Yeah.
Or we've seen a rise?
Yeah, it's been extraordinary. So a lot of programming in place already to deal with that, but this Dulce will help identify earlier and better, we believe.
Joe and then Alyssa.
One thing that Leslie has made me very aware of is this concept of social determinants of health. And
good.
I'm curious about, what you just said in the sense that there's this long history, it sounds like, of pregnant mothers and postpartum mothers with substance abuse issues. Do we have any research that shows what might be the cause of this being higher than you would expect? What's that?
Yeah, you gave your answer.
So is it issues of poverty, issues of?
It's some combination of these issues. And that's why the family specialist is so critical, because they're really not the doctor spending time on the health issues. They're spending time on the real issues at home that are leading to the adverse health issues.
Got it.
So
Very interesting.
that's really critical. And if you look at our state health improvement plan, which we'll be renewing again in the next year or two, but there's still one in existence. The 5 areas that we identified as priorities for the state were child development, substance use, mental health, chronic disease, and oral health. But we identified them in association with social determinants of health. So it was a package, if you will, as opposed to just focus on why are so many people costing us so much money, in terms of mental health and chronic disease issues. It's looking at the social determinants, and it's built on a foundation of health equity. Because that's really, when you further look at data, we may look great in Vermont. In fact, we're one of the healthiest states. I don't want to lose that. But at the same time, even though we're one of the healthiest states on whatever parameter you're looking, if you dig down and look at what we can term marginalized populations, whether that's by racial or gender orientation or disability status or socioeconomic status, that's where you find tremendous disparities in the data. So not every Vermonter is living as healthy as people in the healthiest state are. There's a component of them that are not, usually determined by those areas.
And what was the name of that, the position or program that's helping with the, with
DULCE.
ULC? Thanks.
Dulce. And what it stands for, it doesn't make sense. So I'm not gonna-
I just thought it meant sweet, but, you know, because that's.
Oh, yeah, right.
In Spanish.
Yes.
Yeah.
And nobody knows if it should be pronounced Dulce or Dolce or anything. It is an evidence-based program.
So you were talking about, you know, some of the barriers with the hubs and
Yeah.
obviously, you know, time commitment and, you know, frequency. But I'm wondering, and I know that within Blueprint, there'll be a proposal for the community health teams, which include, I think, the MAT teams that go in, the medication assisted treatment
Well-
teams. I guess my real question though is, how are our spokes doing? Not necessarily do we have enough spokes?
Yeah.
Are there things that we could be doing to increase the number?
So the majority of spokes are primary care settings. Though there are some psychiatry settings, some OBGYN settings that are also considered spokes. The majority are primary care. So a blanket generalization statement can be primary care is not thriving right now. Primary care has a lot on its shoulders. We don't want to actually add to that burden. The whole idea of the Blueprint and its community health teams is to support primary care because so many things that when I was practicing as a physician could not do, the community health teams actually was my extension. So I could be counseling my patients about their nutrition, about their physical activity, about their substance use or tobacco use, et cetera. But I couldn't have it end there in a one office visit. So connecting to the community is so critical. So anything that community health teams can do to augment what goes on in that office setting is really important, including not just the carrying out of what the plan might be, but identification. So screening for whatever you're thinking about, in this case, perhaps mental health disorders or substance use disorders, having the ability to do a brief intervention in the office setting, but then be able to navigate the person to services beyond the healthcare setting, really critical. So primary care is, it's a little bit beleaguered right now. Not just Vermont's problem or fault, because this is really a nationwide thing. A lot of it has to do with attracting people into these specialties. A lot of it has to do with, payments and reforms, delivery service and how that can be reformed. A vision we have, one thing that's really good in the governor's budget proposal that I think everyone's been agreeing on is the increase in dental care. So the Medicaid rate going from 50% of commercial to 75%, that should actually help a lot of people. However, that's still people who already have cavities that need to be filled. What about the ones who we don't want to ever develop those? Well, we're not doing as wonderful a job as we want to be with our very youngest. And our very youngest could benefit not just from some of the school-based programs that are going on and from community fluoridation, which, as you know, is by community, but primary care could assume a role for Blanche's very early years of life. I wouldn't dare put that on primary care. I would lose all credibility with
I
my
actually researched that once.
colleagues. But at the same time, planning that for the future, primary care pediatrics officers would love to be able to participate in that and do that. But we have to make it possible. We can't just say, we're going to shove this down your throat in addition to screen for suicide, screen for anxiety and depression.
I just didn't know if we had been thinking about investing some money into primary care to incentivize more providers to become prescribers. Because it's actually very,
Prescribers of medication-assisted
Yes.
treatment. So
Yeah.
the government just helped us with that.
Yes, sure.
Because they removed the so-called X waiver,
yeah,
which was required a certain amount of training by the physician and limited them into a certain number of patients initially. And it was a hoop to jump through. Now that has been abolished, so we don't have to worry about it. We actually don't think that's going to impact Vermont very much because we have the highest per capita prescription rate for buprenorphine in the country. And I think we're third for methadone in the country. Now, the primary care community can't prescribe the methadone, that's at hubs only, but they can do buprenorphine. We already have abundant people doing that in the state. And it turns out the majority of them are doing 10 patients or less. So there's a number of very high volume prescribers, usually in the addiction specialty world, that are doing a lot of that work. But primary care is doing it across the state. Just for each individual practitioner, it's not a huge number. So I don't think this change is
if we had enough.
going to help that much.
Okay, thank you.
What would help it more is people being identified with the disorder. So the screening part that's being talked about with the Blueprint expansion is really important. And I would say that the opportunity to have more people have this prescribed to them often falls on the person, unfortunately, with the opioid use disorder. Because if you ask 100 people why they're not in treatment, 96 of them, this is national survey data, 96 of them will say because they don't perceive they need it. So when you read statistics like only 10% of people in the country with an opioid use disorder are getting what they should get for treatment, it's not all on the treatment system. It's on trying to work with people who have the disorder in a productive and constructive way to get them into treatment, which takes time. It's a very, like any chronic disease, it takes time. People who are overweight don't just wake up one day and suddenly they're on a diet and they're never overweight again. We know that goes on for decades.
We have a couple questions and I want to end a couple minutes before 10. I'm going to start though, and this is a follow-up. If you can just get back to me on where we are in the budget around nursing scholarships and the dollars that are there and how the program's working, that would be great.
Sure.
So I think what we're going to do is Brian and then maybe Daisy and maybe Leslie. Because we are.
I'll be quick.
So, go ahead, Brian.
Yeah, so just when you're talking about, I know that we were talking specifically here about the role of primary care in the hub and spoke system, but generally for primary care, I'm curious, like from the perspective of the Department of Health, what are the greatest barriers for people to access primary care? And it doesn't have to be limited to hub and spoke. That's one piece. And then the second question is, what are the greatest burdens for the practitioners from your perspective? Because I think we need to hear this from any perspective.
Yeah, so the barrier, we have incredible access in this state to primary care. I think we lead the country, actually. So we're in the high 80s% for people having a primary care physician. Doesn't mean they can always access them, because I talk to people all the time and say, oh yeah, I have a doctor, I just got to accept me into their practice. I won't be seeing them till June, because that's the first time I can get in. But I have a doctor now, which is great. We have an aging workforce in primary care, which is unfortunate, but not untrue of other places as well. And the fact of the matter is, most people can identify a primary care site. The reason that the Dulce part of the program is going to work so well that I talked about earlier is 90 to 95% of all newborns are actually seeing a pediatrician or family practitioner in the first 6 months of life. So they're connected to that setting, so they can be connected to the family specialist who can help them with these other problems we talked about. And your second question, I think, is just the fact that over time, mostly through quality and performance improvement programs, mostly through payers like Medicare and Medicaid, who often drive this. There are lots of things that people have to do to be at the top level of their practice, so to speak, having the best sort of statistics and data about how many people are they screening for this, how much access do they have in their office for that. So there's a lot of requirements that have been put on them. Fortunately, things like community health teams can help with a lot of that, but they can't help with everything. So for many offices, it creates just an undue strain and stress because you're trying to figure out, am I managing chronic disease? Am I managing somebody who has an episodic illness and just needs me to see them and make a quick diagnosis and offer treatment? Am I actually screening for suicide every time they walk in the door? And these are all like important priorities. But they're very, very challenging when you come down to the level of the practice itself. Hope that gives you a little view of that.
I was wondering, just in terms of the cost for people, what the barrier might be, like to access, like there, like you said, people are waiting to get in. How do you hear much about people who are not going to the doctor because they can't afford the copay?
Yes. So again, you're going to hear a lot about people who have high deductible plans and just try to save it up for when they really get sick, and they don't want to actually use it for anything before that point in time. That's not, Vermont shares in that problem, but that's a federal level problem as well, obviously. And not only do people have to, even if they have very good insurance, they have to pay copays, but I don't really hear about that being the barrier. Because $20 to $25 is different than $6,000 of expenses that I'm going to have to pay before the insurance kicks in.
I think mine is 7,000 or something like that.
Yeah.
So unfortunately, Daisy and Leslie will have to come back. This will not be the last time we have to in here. We appreciate your time, and I am hopeful that your staff is back to some semblance of normalcy after the pandemic, and we appreciate everything that you do for us.
Thanks for having us.
Thank you.
Yeah, thank you very much.
We're gonna we are still on air, everyone. We're gonna let AHS set up, and then we'll go right into that presentation. I know you have to go.
I can hear you. I've had nothing but IT days. I guess it says it's plugged in, it's got a light, it's like, it's nothing.
Absolutely.
Okay, we just heard you.
It's like, it's making sounds too. It's like over here. Oh my God, it's so hot.
It is.
It's probably being hacked by Russia.
Whatever you need for chairs, that space at the end is empty. Perfect. So you can use that chair, or there's a chair behind you. There's a comfortable chair and probably an uncomfortable chair.
Reboot it.
Did I what?
Reboot it.
I don't even know how to.
Good to see you both.
Thank
you. Welcome. Are we ready, everyone? Brian and
I'm trying to help her.
Okay, I think we're going to stop helping and be ready for testimony. Great. Welcome. You've been in this year, right? Or no? Should we do introductions?
I was online.
That's right. You were on Zoom.
Yeah, I apologize that I didn't make it in person, but it is so nice to actually see everyone in 3D.
Great. What's wonderful. So welcome, and we're going to let you kick it off.
Okay. Good morning. For the record, I'm Jenny Samuelson, the Secretary for the Agency of Human Services. And again, it's great to see everyone in person. This morning, we're going to run through a high level of the agency's budget and how we got there. I know that you've had many of the other departments in already, so I imagine that this will be an opportunity for dynamic conversation and discussion. So I'll leave it to you, Chair, to interrupt as you see fit.
And just so you know, we've only had BDH. The rest are after you. So perfect.
So the Agency of Human Services this year, as we engaged in our budget process, did it a little bit differently. And I think it's important for us to recognize that. Coming out of the pandemic, we had really seen a vision of the agency coming together, working across the boundaries of departments throughout the pandemic, come to fruition. And so when we approached the budget this year, we really approached it as a whole agency budget, with the commissioners and others really working across departments to first identify our strategic priorities and our goals, then to align our policy initiatives and our budget process with that. And so it was, as you look across it, you may see that some departments have different levels of investment. That was actually decided on as a leadership team among the commissioners collaboratively together based on what they felt like were the priorities.
Everyone's trying to get out of silos.
Exactly.
It's fabulous.
And this year, I'm having been at the Agency of Human Services for quite some time, even before I'm in the current role. I would say I'm optimistic that it's the first time that I've really seen us do it at a budget level in a way that we haven't before. And so you should see, because of that, that this represents some core themes: stabilizing our healthcare system, our focus in on childcare access, really targeting investments towards mental health, really aligning a co-occurring mental health and substance use system of care. So as we move forward, the first topical slide really is an overview of the agency's budget. I'm not going to spend a huge amount of time on this slide because we're going to go into each one of these areas in more detail. But overall, the agency, as we talked about before, is the largest in state government. Our request for next year is $3.2 billion across all of the 6 departments. So Disabilities, Aging, and Independent Living, Department of Mental Health, Department of Corrections, Vermont Health Access, Department of Health, and Mental Health. So really across all 6 of those departments, it represents a commitment to serving vulnerable Vermonters that we haven't seen before, with an over 10.82% increase in the agency's overall budget. And as I go forward, I'm going to go through the specific initiatives that we're really highlighting. And then I have here with me today, I should have introduced from the beginning, Rich Donahue, who is our CFO. And we'll go through in detail the numbers at your discretion for each one of the department's budgets.
1 second. Listen.
I just wanted to clarify, you said 10.82 budget increase, but
Percent.
about the general fund increase.
That is the general fund
That is the
Okay.
general fund increase.
What's like the total increase?
The total increase across all funds is an amount of $327 million across all funds. I can give you that percentage in just a moment.
Okay.
Great.
Positions, 3,741 positions. Is that up from fiscal year 23, the year we're in?
It's a perfect transition. It's up by 2.4%, which represents a total increase of 73 new positions. You had Dr. Levine in here before, and so you had an opportunity to hear about some of the work they're doing. Approximately half of those positions are in the Department of Health, 32 of them. And so the rest of them are throughout the rest of the departments and agencies, some of which we will focus on in specific initiatives that are proposed.
And as we heard before, some of them, I believe, are limited services positions tied to some federal grants.
The majority of the funds, particularly those positions, particularly those that are coming into the Department of Health, are limited service. You'll also see some conversion of limited service, and you can ask Diva about this in more detail. That's where the majority of them are limited services positions to permanent positions. So overall, the investments that we are making into core initiatives into the agency, the first is focused on childcare. And when we look at childcare, it's increasing the subsidies for the childcare the childcare subsidies to families from 350% of the poverty level to 400% of the poverty level. What you see is that this is a significant budgetary investment because in this band from 350 to 400, there's a significant number of families who encompass that range. And we believe it'll increase access to childcare. You're also seeing expansion of the of subsidies in the after school and enrichment programs and again to address access issues for families who that might not have been approachable or affordable. We're also equalizing subsidies across providers. Now, this is one that I think is important for us to gain some context on. Previously, for many good reasons and good intentions, the child care subsidies rate was based on the STARS rating of the child care centers. What you see here is that in many of our communities, those larger child care centers have more capacity to go through the process, become 4-star rated facilities. And we have many in-home who can as well, but there's a discrepancy in those two. And so in our smaller, more rural communities where you see more in-home providers, you see an inequitable access to the higher level of subsidy. That subsidy isn't the amount that the provider gets paid. It's the amount that the family has access to pay their child care provider. And so what we recognized was while it was a good intention to help increase quality, there are probably better ways to do that while making sure that families have equitable access to the same subsidy. And that's what this really addresses. So it's not taking away quality. Additional quality efforts will continue, but it is addressing an inequitable distribution of those funds. And the last it's $56 million to administer these programs. DCF is looking for 6 permanent positions to implement and sustain the expansion for the distribution of those funds.
And I'm just I know Art, you have a question, but I'm gonna just remember what the jurisdiction is of our committee versus Human Services. So this is good for us to understand, but we're not gonna go into a deep dive in the childcare since that's really Human Services purview to do that policy work. So Art, not to say you can't ask your question, but I don't want to spend a lot of time on it. So we have time to go to what is under our jurisdiction.
Okay, but this isn't a deep dive, but I would like to know, are we giving a stipend to folks to pay for childcare, or are we providing the childcare itself?
So the way that the CCFAP program or the child care subsidy program works is that an individual family becomes eligible and we then pay the child care provider for the services that happen. Each family was determined based on their eligibility, the amount that's accessible to them. And then the state doesn't provide the care. We provide the money to the private child care providers.
Okay, so you directly give the money to a private child care provider?
Yes. Yep.
Okay, thank you.
Okay. So in addition to that, we've got, which is focused on DCF, we also have $6.5 million of general fund that we are investing in the emergency shelter program in order to sustain and expand their capacity. So what you see this year, this is paired with in BAA, where you see a capital investment to bring the number of shelter back to where they were and then even higher than where they were before to address our housing crisis. And this is the ongoing services that are necessary to continue to keep those beds open. So an investment there. The jurisdiction of this committee really is in healthcare. And so I want to point out the next one specifically. When we approach our healthcare this year, we are looking at how we can stabilize the healthcare system, and you'll see a significant amount of investments around that stability, as well as looking at how we can create sustainability going forward. So there are key investments in that stability. And this summer, the Agency of Human Services worked with providers to identify what their priorities were related to stability. If you haven't seen it already, we can make sure that you have a copy, but there were a list of particular initiatives in the budget. You see many of the financial investments into that. So the next one would,
I'd love to see that list.
great,
That'd be
we can go ahead and we can send that out to the committee. And
Perfect.
that matches up really closely with many of the investments that you see here. Again, efforts particularly related to financial investments for stability, and then sustainability in some of our work to work hand in hand with hospitals and with our organizations on an ongoing basis. So for private non-medical institutions, which is another way of saying many of our residential programs, and you'll see this in both Department of Mental Health and Department for Children and Families. These are residential care programs. Their rates are based on costs. And so and we can see that, and that's different than some of the other providers that we work with. We actually have cost-based reimbursement for these providers. And so we recognize, looking at that, if we base their rates on rates from 2 or 3 years ago with the inflationary pressures, that we are not keeping them open. And so it's critical that we bring back online our children's and our children's system of care and our mental health beds, which in our children's system of care, they were down at about 45% during the middle of the pandemic. Not only was it beds closed, but due to staffing and payment and the general pandemic. But now, as we go forward, it's whether they stay open or not. And so this is an investment in stabilizing that system. You'll see it again repeated in the DMH budget. It's also contracted staff to support the FSD historic caseload.
What is FSD?
The Family Services Division. Working really hard on acronyms, so please stop.
So we will.
So the Family Services Division has seen some caseload trends. You'll see that in most of our budgets. It's really trying to address that. Moving forward into Dale, what we know, and this is mainly human services, but has an overlay a little with healthcare, is that we are seeing more individuals come into the Office of the Public Guardian, and over the since about 2008, when they had positions cut, there weren't additional positions added. So as that caseload has increased over time, we are now significantly above what the standard is considered for the Office of Public Guardian. Where that intersects really is that it is those individuals who are under public guardianship are in our developmental services system of care and in our adult system of care. And so we're seeing some of those individuals get stuck in our system. So making sure that we have those positions and reducing their caseload helps us move the flow. And that's a key theme to our stability work, was addressing not only the regulatory pressures and the financial pressures, but also flow in the system. And so that's one place there. You'll also see in Dale, home health, long-term care rate increases and a DS system of care stabilization. And so really trying to make those key investments. I want to point out that one of the things that you don't see in here in terms of a budget pressure up is that for our home health agencies, they lost funding at the federal level, 1.9% year over year for Medicare. That created significant pressures on those agencies and destabilized them in a way that we haven't seen before. So the way that we've addressed that is to sunset the provider tax. So you won't see that in the budget, but you will see that as a key way to stabilize that system of care.
And just for our benefit, we will have a session on provider tax because we haven't taken that up yet. And we will have policy input into Ways and Means, who will also have already started that conversation. Art, you had a question?
Yeah, just a quick question, so I understand the site. When you say invest so much money, that's new and additional is additional to what was last year?
Yeah, the investments are additional to this year, yes.
Okay, so invest means we haven't got anything in there now and these are new.
No. And investments often means, mixed messages. Here are initiatives we are taking, and in some cases, you heard about the blueprint where from Dr. Levine, that's a level of expansion of an existing program, and what I mean by investments there is it's new services. In some of these other areas, it's financial investments in services that already existed. So for example, in the home health realm, there are investments in the Choices of Care program. It's a program that already exists. It's addressing the fact that there are some funding gaps in that system and that we need to make those up.
So it's additional dollars into programs that are already exist.
Okay, well, it says
Already
additional and
invested in.
invest, and I'm confused on
Sorry.
that, so.
That word is confusing. Yeah.
So you invest 56 million in childcare, what was the budget last year? Do we know?
The total budget last year for childcare?
We can get that for you.
Yeah.
I don't want to speak off of the
tips.
top of my head. It is significant when we look across the programs, what we already invested last year. This is an historic additional investment. But what you note is that these are existing in childcare. These are existing programs that they're adding funds.
Well, that's what I'm trying to get,
Yeah.
is how much is
Yeah.
actually
So
added.
we'll get that. We'll get that.
Okay,
for you.
yeah, no.
I just don't want to speak off the top of my head.
And we're going to have,
Right.
hopefully have Sarah Clark from the JFO office
Right.
come in and give us a 101 on how to read a budget. So we can answer some of the questions of, well, where are we starting and what does that mean?
Yeah, don't feel pressure to do it now. We can wait
Okay.
till later. We got plenty of time.
Okay.
Leslie, this is just to add to your research. I'm just curious to know how many families, when you increase from 350 to 400%, how many people does that affect?
Significant. Rich,
Yeah.
do you have that number?
I don't have that number.
Yeah, but
I'm gonna phone a friend here. Shayla, do you?
I'll get it for you.
Okay,
Yeah.
so we'll get it for you, but it grows the program exponentially versus just adding.
Yeah, does it add 10 or does it add 10? Yeah, whatever.
Let me go ahead and bring those numbers back to you.
Thank you.
Okay. When we look at the Department for Mental Health, there's $2.3 million of general fund that we're adding into the Department of Mental Health. I think here, again, we're talking about provider stability and sustainability, but we're taking a different approach. What the Department of Mental Health has done is they've looked all the way across their system of care. They have identified, they are working currently with the designated agencies and others to really define what the core services are that they provide and how much that costs. We don't have that insight right now, and we haven't historically. And so really trying to make sure that we right size that investment. But while that work is happening, we knew that we needed to look at where there were gaps in our current system. And so, and in that work with the designated, it's also getting some equity across the state because services aren't equitably distributed. So in our new investments, which really help to infuse funds into the system where we need care, and much of that's going to designated agencies as well. What you see is us identifying core services that Vermonters actually need. And so for that, it's mobile response expansion. In mobile response, it's people going out when someone is in crisis. And it's making sure that we know that we have that service in place across systematically across the state where it's been available before in smaller pockets. It's alternatives to the emergency department. So it's a place for people to go. And instead of just going to the emergency department that may provide a better therapeutic environment, oftentimes this is in collaboration with the designated agencies and the hospitals and others. It's also an investment in the residential programs that we see. So again, the Department of Health really looked across the system of mental health care, and you'll hear Commissioner Haas talk about someone to call. You'll hear her talk about someone to ask. That's the getting it in primary care. Someone to go to where you are, and a place to go. So really trying to go from that prevention of having someone ask all the way up through the crisis system of care. Okay. We also have $5.7 million of a general fund investment in the Department for Vermont Health Access. This is targeted at increasing our dental rates. Medicaid has paid about 50% of the Delta dental rates in the past. And in order to ensure access on an ongoing basis for individuals who are currently on Medicaid, they're now moving that up to 75% of the Delta dental rate.
Answers for those questions. I have a few answers for the questions asked earlier, if I may. So again, for the record, Rich Donahue, CFO for AHS. I believe the question was, prior to the CCFAP subsidy expansion, what was the base budget for that program? It's currently $62.8 million. And in terms of the number of children that would be served with the increased federal poverty level change, that would be 4,664 additional eligible children.
Great. Good job. Do you have a question?
No.
Art, and then Leslie.
Yeah, where was I going? Okay, the dental piece. So to increase that 25%, it's going to come from the general fund to do it.
So the way that dental is paid for,
Right.
And the way that Medicaid generally is paid for, is that the state puts in a matching amount, and then the federal government puts in an additional matching amount.
Gotcha.
So this is 5.7% of the general fund, and that will be matched up against
Gotcha.
Yeah, that would gross up to about $13.1 million in total.
Yeah.
The matching,
Yeah,
the state
right.
fund matching portion is 5.7 million.
Okay.
Leslie?
I just want to understand, is that done by a rule change? Like when you make a change in the Medicaid rates, is that a rule change?
No, it's done by a rate change. And so there is a public noticing process that Medicaid goes through whenever they make a significant rate change or a rate increase.
Okay.
But it's not a rule change.
Okay, so, yeah, I just, not.
And it's a budget issue because it requires additional state dollars.
Yeah.
So, but this
It's not a
isn't,
technical correction. I'm just trying to understand how it fits into that other bill, the technical correction that Diva's asking for.
like, we can ask Diva when they come in.
Okay. I think that that's probably the best way to get in depth with them is
Lori,
to.
can I have a follow-up on that? So that increase goes to the provider, correct?
Yes.
Okay, just want to.
Yep.
So it makes it more palatable, or it encourages that person to handle the dental problems of the individual.
Correct. Yeah, essentially what our dental providers are saying is that this doesn't cut that at
They don't get
a
enough.
50% of the dental rates. It doesn't cover their costs.
Sure.
And as such, they have to make a very difficult choice or decision about whether to serve individuals who have Medicaid.
Gotcha.
And so we were seeing a significant number of practices who were making the decision to not treat Medicaid beneficiaries, which just as a reminder to everyone are individuals who are low income or who have disabilities and don't have access to other insurance.
Gotcha, thank you.
Okay.
Oh, sorry.
Well, I guess I wasn't going to ask. I was going to ask that instead. But do you anticipate that by raising it from 50 to 75, that you will have more providers start providing services?
I would definitely reiterate that question with Diva, but that's the goal. The goal is that it would prevent some providers from discontinuing treatment, and it would incent other providers to provide treatment.
And we will have some providers come in.
Yeah.
Okay, so those are the overall sets of initiatives. There are some one-time initiatives, and I did hear you talk a little bit about that with Dr. Levine. The first one is for the Blueprint for Health and the Department of Health in collaboration. Remember, we're working across the boundaries of departments. We are proposing a 2-year pilot for $9.2 million general fund that matches up to a little over $20 million of global commitment funds to expand the hub and spoke program. The hub and spoke program, I don't want to repeat what Dr. Levine said, but the hub and spoke program has provided treatment in primary care practice for individuals with opioid use disorders. But I want to make sure that we're clear this is not just treatment. The focus of this expansion would be for, from all the way from individuals who are just born and infants up through adults. And so folks ask, well, how is that possible? There are two components. One is screening and brief intervention. So if we think about for those of you who've been involved with the Blueprint before, under their Women's Health Initiative, they've done screening for mental health, substance use, violence in the home, housing insecurity, food insecurity, for individuals who are systematically coming into the practice. That's our early intervention, and embedding staff not just to do that screening, but to do the follow-up. So if individuals have unmet needs in those areas, they can do brief intervention. And we're now pairing that with what we do in the hub and spoke, where individuals are embedded in the practice to provide ongoing treatment and primary care for individuals with lower acuity, and then connecting them to hubs, which are often substance use treatment hubs or the designated agencies, depending on their need. In this expansion, we're expanding that screening, and we're making it co-occurring for the substance use component. And the co-occurring is co-occurring with mental health, and also co-occurring with other substances, because the needs of Vermonters have shifted and changed. When we began Hub and Spoke a decade ago, the real pressure was on opioid use, and now we're seeing the substances change. And so really making sure that we're doing co-occurring whole person treatment in primary care, relieving some of the burden of the lower acuity so that people get care where they want to get it, and allowing the rest of the system to work with higher acuity.
So again, breaking down those barriers, right, across silos, which we're all trying to do. I'm going to ask you to ask your question about community health teams and providers. That you asked Dr. Levine.
Well, I'm just wondering, I mean, we have the hub and we have the spoke, and what are we doing to support the spokes? Okay. And how are we investing? Because, I mean, I know that in the primary care specifically, because there's a lot of barriers, and it's not just about having the community health teams come in, but there's a lot of barriers for a provider to be able to invest their time, energy into, treating patients. Patients need to be seen very frequently. Oftentimes they're on Medicaid, which is low reimbursement. And I'm just wondering if we're investing in our spokes to make sure that we have enough prescribers around the state.
Yeah, that's a great question. And it's been, I think what you'll see is 15 years of actual focus on primary care, a lot of which has been through the Blueprint. The need for us to expand the hub and spoke model, and I hate actually talking about it that way because it's much more than just hub and spoke, but the need to expand our community health teams came out of conversations and discussions with practices about what the very real pressures are that they're facing right now. Similar to when we implemented the original hub and spoke model. They need additional staff in their practices. They can't keep doing the work of screening and brief intervention in their practices and do the work as we've seen coming out of the pandemic, where there's more pressures on our mental health and substance use system of care. They can't do that work without having additional staff in their practice. Is it the physician that needs to do that work? They would tell you no. What they really need are embedded in a team that embeds mental health and substance use professionals, as well as community health team workers, into their practices, so that they actually have the real resources, the people in their practices to address those challenges. Other investments that we've made include, if you look at the ACO model, they've made significant financial investments across all of the payers who continue to be involved in the ACO. They've taken and provided additional care management payments and additional per person per month payments to incent primary care, as well as coming up with alternative payment models that actually fund a budget to that practice versus a fee for service payment. And then you've got the Blueprint overall, who invests both per member per month in the practice, as well as the base community health team that we're building on here. Does that make sense?
It does. Can I ask a follow-up?
Yeah, please.
So the request for Blueprint, it's to go to the community health teams.
And
When is the last time the per member per month to primary care has been increased?
So again, the request to increase the community health team specifically addresses what the practices said are needs in their practice. It is money to fund staff in their practice. The per member per month, the last increase was 2017 or 18, I believe, at the same time that we increased we also increased some of the incentives for additional community health team members. But again, when in talking with many of our primary care practices, that per member per month is not the only financial way to address their issues. The more comprehensive approaches that we're seeing in the ACO are the better ways to deal with the overall finance component of the primary care, while this helps to actually provide the resources that they need to augment the care in a very real way. Those two things come together. But the real work to change the payment system for primary care, I would reflect back to some of the work that we've done in the ACO and in the all-payer model. Yep.
And before we go on, I apologize. We have a question that's going to settle a little dispute between Alyssa and I.
Okay.
Where does Blueprint sit? Is it in your in your office, or is it part of DIVA?
It's a great question. So we aligned Blueprint with healthcare reform. And so, but, so you're both right.
Of course.
So the history of the Blueprint is originally was the Department of Health. It moved to the Department for Vermont Health Access when the Director of Healthcare Reform moved to the Department of Vermont Health Access prior to the Shumlin administration. Its budget continues to sit in the Department of Vermont Health Access, but we've realigned it over the last 2 years to sit under healthcare reform because it is a multi-payer initiative. It is not just a Medicaid initiative, and it really can provide the transformation that we need in parts and sectors of our healthcare system. It really has been a driver of change, and that's what its original intention was. And so we realigned it and put it underneath the Director of Healthcare Reform, but its finances and budget sits in DIVA. So you're both right.
Thank you for settling that.
Okay.
Okay, we can move on.
Okay. So that's the Blueprint investment. Again, that's in alignment with the Department for Vermont Health Access, Blueprint, which is the agency, and the Department of Health. And you will see that the clinical model for young children, we have always defined the clinical model is the DULCE model, but DULCE simply is screening and brief intervention for very young children. It's the evidence-based way to do that. So moving forward, again, with the theme of stabilizing our healthcare system, last year, the Agency of Human Services had a fund that was called the COVID Contingency Fund that we were able to use to stabilize healthcare providers and to make key investments that would address some of the flow in our systems. Examples of that include providing payments for extraordinary financial relief to providers that would not have otherwise been eligible when they were about ready to shutter their doors. Other investments include opening up long-term care beds in skilled nursing facilities at moments when our hospitals were experiencing significant pressure, and yet the staffing pressures at the long-term care facilities were not allowing them to open up beds. So this is an opportunity to refresh those funds, recognizing that our system is not fully stable at this point in time, and allowing some flexibility for us to continue to be able to make those relief payments or invest. I know I keep using investments, relief payments, or actually targeted targeted investments when we see a challenge or an issue in order to stabilize the system.
So will this be a grant process, or it's more of a, we see problems in these areas, we're gonna?
It's a great question. It's not typically a grant process. I kind of gave two separate ways that this has happened, and I'll let Rich weigh in here as well in terms of the mechanics. There are requests for extraordinary financial relief. They come in, those organizations provide us significant documentation on where they are financially. I'll draw from a recent example. A home health agency wasn't able to make payroll, and they were behind in arrears on payments to their vendors. They provide us with the financial documentation that demonstrates that. We work with them to try to come to a sustainability plan, and then we'll make those key investments to try to stabilize those organizations in our healthcare system. And so that's a request process that comes in to the agency or to a department, because some of the departments already have processes for extraordinary financial relief for some types of providers. We do the review. If the departments aren't able to fund that, we draw it from the agency. In other cases, like our long-term care facilities, it's augmented payments. Rich, I wonder if you can.
Sure, yes, just as you were saying, the nursing homes and PNMI's private non-medical institutions have an extraordinary financial relief related provision, and our ability to be able to provide that type of stability payments outside of this fund. So this fund's intended to target other providers that don't have that type of circuit breaker available to them otherwise.
But there are some other places that we've provided funds, so the mechanisms for that. So for example, to the long-term care facilities.
Exactly. Another good example is match for the supplemental dish payment that went out this year. This fund was the source of the state matching funds for that one-time supplement. And that was obviously targeting hospitals. Another good example would be the home health organization that you just mentioned. They were not able to make payroll, but they were concerned that they might not have the available cash flow to make payroll, and we were able to provide an advance payment to them, subject to a sustainability plan. So it's those types of exigent circumstances that may arise that can't be otherwise addressed through other funding sources and other mechanisms.
Is there money still in the fund from the previous allocation?
There is money in the fund currently. It's $4.9 million.
Yes.
I tried to leave the numbers to Rich, so
yes.
I don't.
That's exactly right.
There's $4.9 million in the current fund, but we've received enough requests that we know that we will likely exhaust that before the end of the year. And there are some examples of where hospitals have proposed mechanisms to improve the flow for mental health and long-term care patients that we are contemplating and considering. Those exceed that 4.9%. We have not been able to make those investments in the types of things that they have, which, for one hospital, it's reopening a floor for long-term care patients rather than keeping them on med surge, as an example. For another, it's retrofitting rooms in their emergency departments because many of them were built a long time ago and they are still have curtains between spaces. And so it doesn't provide a therapeutic environment for individuals who have mental health, who are there for mental health concerns. And so trying to provide a more therapeutic environment. It's investments like that that we haven't been able to make yet. We're seeing the extraordinary financial relief requests.
Right.
We're having to balance those two. So this will help us be able to rebalance that.
Okay. I think we have a couple of questions, Leslie, and then Art.
I really appreciate, I'm from the Springfield Hospital area,
Yes.
so of course I have concerns about hospitals, stability for sure. And just wondering if this is the fund, we have Act 167. Is that where this money comes from, or how does that all interweave with hospital sustainability and stability?
I'm glad that you've asked that question. This is more for extraordinary financial relief.
Okay.
So if I go back to what I mentioned before, the agency has been working on stability and sustainability. When I think about that, for me, the pandemic has really honed my efforts in those areas right now into 4 key areas: primary care, skilled care, which sometimes folks call long-term care, but really is home health and skilled nursing facility care, mental health and substance use co-occurring care, and our hospitals. So under 160 set, we know that we need to do stability work with our hospitals, and you'll hear a key theme, whether we're talking about in each of these areas, what do we need at the local, regional, and statewide level? So working with the Green Mountain Care Board, the Agency of Human Services has been looking for a vendor who can do, can look at exactly that local, state, and regional level, but also, in addition to doing data, because we don't need another study that ends up on a shelf, doing work more like what we did with Brattleboro Retreat or Springfield Hospital, which we've gained a ton of learning from. And I'm going to talk about the Brattleboro Retreat because that's the most recent and probably most successful case where we dug into and looked at each one of their business line items, compared that to the needs of Vermonters, identified where they were losing money initially. And then the Brattleboro Retreat, not the state, but the Brattleboro Retreat made a decision based on conversations about what the needs were to shut some of those lines down. So for example, their hub, which was providing opioid use treatment, there was a hub in that region that could accommodate all of the need. And Brattleboro Retreat was losing $1 million a year. So they made the decision to cut back on that. But they're also, what I want to recognize is that for many of our areas, as demographic changes shift, we need we actually probably need more capacity in some areas. The Brattleboro Retreat, we recognize that there were areas that we needed capacity. They're making key investments in that, but we also recognize, after looking at the costs for those entities and organizations, a deep dive in the costs, that we needed to adjust some of our rates. So in our 167 work, which is not to be mixed with this stability fund, but money that was provided to the Green Mountain Care Board, we are looking at a vendor who can do both the analytics work, quantitative and qualitative, so quantitative data, but also listening and hearing from communities, and then working with hospital boards to do the type of work we did with the Brattleboro Retreat. That's progressing, but everyone prioritized stability of the system first, that they would not be able to engage in that discussion and conversation, because for the hospitals, they'll come in and they will tell you that right now, it is worse now than during the pandemic. With what they're facing, and so they needed to do that stability work first.
Yeah.
If that makes sense.
Yeah. So how close do you think you are having a vendor?
They are imminently picking the vendor
Great.
and negotiating that. We have had one region who has asked to start that work earlier. And so we're looking at other funds that we can access to begin that work while we wait for that broader stability work. I do want to emphasize that we know that our hospitals, not only do they perform a function for the health of and I'm not saying just healthcare, but for the health of our communities, they also are an important part of the economic fabric of our rural communities. And so really what we're looking at here is defining what it is that the future of hospitals look like, and where we need to make appropriate investments in order to keep them playing both of those dual roles. And
I really appreciate your comments because they care a lot about how this moves forward, obviously,
yes,
because of my region.
So we've gotten a little off track of the budget. Chair, I'm looking at you to make sure that we're on track.
And we're going to go to Daisy because she hasn't asked a question yet. All right, we'll get to you eventually. Go ahead, Daisy.
I don't know if you're there yet, but I wanted to hear a little bit about the 1 million general fund for refugee resettlement assistance. Is there any detail you can give us on prospective programming to be tied to that?
So that plan is emerging. What we know is that we want to make an investment in this area. We know that we've got a lot of organizations across the state right now who are serving our refugee populations that with enhanced funding could ensure that they are able to serve more refugees and do a better job at helping them make the transition into the workforce. What I would recommend is to have Tracy Dolan come in and describe that in more detail. this was a place that everyone knew we wanted to make an investment in our services. So this is a commitment on the administration to do that, but the plan for how to utilize those funds is still emerging. Okay.
All right, let's keep going and then Art will come back to you.
Okay, so since we've covered the refugee assistance program quite well there, I'm going to end the basic overview of our budget to look at a $2 million that's being put into the Reach Ahead program. So the Reach Up program serves many of families through the Department for Children and Families in order to get them employed and stabilized. These are families with young children. But once that happens, their benefit stops. And so the Reach Ahead program allows that once they've gained some level of stability, rather than stopping their benefits, it smooths that cliff down so that families continue to get the supports and services that they need so that they can continue their level of stability to a point at which we feel like they will be independent. And so it really is rather than having a benefits cliff, really creating a smoothing of that for those families who are really working on getting working and stabilized. Okay, so that's the basic overview of the budget, and we've delved into some of the policy areas, but I think what you've highlighted is that we really tried to align the policy direction that we're going with our budget this year. And so that's evident in our conversations about our mental health and substance use system of care, our provider stability work that's happening and ongoing, and key priorities of the department and agencies.
And I'm assuming you're okay if we skip the rest of the slides, since we'll be going over these unless you have specifics you want to talk about on the numbers.
I will leave it to you, Chair, to make that call and decision. Is there anything
you wanted to highlight?
No, unless you want to know anything specific about the Secretary's Office budget and the global commitment appropriation. Other than that,
why don't we do that one and then we'll skip the other ones. Can you hold your question? Or?
Okay, sure.
Okay.
Go ahead. So, actually, could you back up one slide, please?
I can.
Thank you. So the first thing I wanted to do is answer a question Representative Black asked earlier in terms of the overall all funds increase year over year in the governor's recommended budget. That is 6.9%.
Okay.
Across all funds. Okay. So I think for this committee's jurisdiction, what might be of most interest is you'll see here $1.2 billion in general fund proposed in the fiscal year 24 budget. 50%, that orange slice, is for matching funds for global commitment. So the Secretary's Office has an appropriation that serves to house both the state matching portion of global commitment appropriations and the federal funds that we earn for global commitment. And then the very small blue sliver at the top is really the administrative costs and the cost of a few boards that reside within the Secretary's Office. So I just wanted to point that out as a general piece of budgetary information for this committee. That's the matching funds engine, so to speak, for all global commitment and Medicaid expenditures across the state.
Which is that higher than is the percentage higher than it was last year?
No, the percentage is roughly the same.
Okay.
It tends to grow in proportion as it turns out, year over year, but that is not a marked percentage share increase of general fund overall.
Okay. Great.
Then if we go to the next slide, thank you, Shayla. Just very quickly, I wanted to point out that there is a backfill of $10 million in general fund of one-time funds that was built into the base budget for matching funds for global commitment. And other than that, we just see a benefit for enhanced federal medical assistance percentage funds, FMAP. Mm-hmm. We are going to receive a benefit of approximately 8.2% million more in federal funds in 24 than in fiscal year 23, which reduces pressure on general fund. And those are the major moving parts. So I don't know if folks have any specific questions.
So is the FMAP change due to the enhanced 6.2% that's going away, or is this the normal FMAP process that happens every year?
This is the normal FMAP process that happens every year. There will also be, during the first 6 months of state fiscal year 24, enhanced FMAP associated with the public health emergency. Yep.
Great.
Yep.
Okay.
I'm just feeling very dumb here. So what I'm seeing is the base FMAP is, you say, is going down, except the percent's going up. So I'm not sure I understand.
So to be clear, the federal participation is increasing, and therefore the dependence on the general fund share of total costs
I see.
is decreasing.
Got it.
But to the tune of 8.2 million.
Understand.
Okay.
Thank you, I'm sorry.
No,
And I don't know what SHCRF
Has that too.
Yeah,
State Healthcare Resources Fund.
thank you.
That is a special fund that serves as a source of matching funds for FMAP.
I thought we got rid of that, no?
We moved most of it out. The only things left in there are like some premiums and some other stuff. It's very small compared to what it was.
Okay.
Greatly diminished, yeah, beginning with state fiscal year 2018, I believe.
Yeah.
An FMAP is quite complicated, so I think it's important to pause and reflect on it. So I appreciate your questions.
I understood it for about 30 seconds.
So wait a minute, I'm gonna put it in my human language. Essentially, the federal government is saying that they're gonna put in 56%, and it means that we only have to put in the 44%.
But that changes based on.
That changes every single year at the federal level, how much money they give to us, which means sometimes we have to, if they reduce what percentage they put in, we have to put more state dollars in. If they increase it, we have to put in less. The challenge here is that a little percentage increase or a little percentage change is a big deal in terms of the amount of money that we have, because the Medicaid budget is a very significant portion of the state budget. But Sarah, I'll turn it back over to you.
We have two questions, Daisy and then Alyssa, and then I think we'll call it today.
Very quick question. Why is the enhanced FMAP of 85% on your downs? Hasn't it always been 85%?
That is a great question. That is an enhanced FMAP specific to mobile crisis, the mobile crisis program. So it's eligible for an 85% federal match rate. So with the expansion of mobile crisis that the secretary spoke to earlier, that increase in costs for fiscal year 24 also results in an increase in federal participation and reduces the amount of general fund that would be otherwise necessary. So we just wanted to point that out, that is yet another source of the enhanced federal matching funds.
That's been 85% though. That's not a change.
That is correct. That has not changed. It's just the amount that we're spending in total is proposed to increase in fiscal year 24.
When we went from 4 programs to now a statewide program, the amount of money that we're actually putting towards mobile crisis is higher. So the amount of federal funds that's coming into the state is higher.
Got it. Okay.
That's just what Rich is trying to point out here. It costs less to run 4 programs. It costs a lot more to do it statewide. And so more federal funds are coming into the state for that. But you're right, same percentage. Just a lot more money.
I'm just curious on your next slide, actually, the eliminate VCSR and
Under
modification to prescription benefits under DIVA.
And what's VCSR?
What is VCSR?
That's the Vermont cost share reduction. That's a state subsidy for those who participate in the ACA health insurance marketplace.
So let's break that down a little bit. The ACA health insurance marketplace is the exchange. So individuals and businesses can purchase a health plan on the exchange through Blue Cross Blue Shield, MVP, and other providers. This is a subsidy for their prescription benefits.
And also direct services, the cost share that a beneficiary would have to pay out of pocket.
Like copays?
Correct. Yes, because of enhanced federal subsidies that have resulted from recent federal legislation, this is a proposed decrease in a proportionate share of state-funded subsidies. And it is, it's forecasted that beneficiaries should be held harmless as a result.
Yeah, so this isn't a change to Vermonters. This is essentially saying there's more money coming in from the federal government to cover the same costs that Vermont would have paid. So Vermonters won't see a difference, but instead of their benefits being paid with state funds, it will be paid with federal funds.
I was wondering, did Nolan?
If you're still confused, I can explain it differently. But that's up to you, or
No,
offline.
No, yeah, offline's fine. Yeah, that did explain it. Thank you very much.
Great. I was gonna ask a question, but I will ask it of the individual departments. I think we're good. Thank you very much.
Thank you.
For being here and providing this overview, and we